We have all heard of ketamine, a well-known medicine used in healthcare. But today, there's a related substance called esketamine, also known as the S enantiomer of ketamine. This medicine is given as a nasal spray and is known as Spravato. It is used in certain cases of depression, especially when standard treatment has not worked well enough. Do you know how esketamine works in the body? What side effects can it cause? What medicines are used to treat depression? Are there drug interactions to watch for? Can it be used alone to treat depression? Or is it usually added to other antidepressant medicines? This is a very important episode. Stay with me. Peace be upon you. I am Hussein Lotfi. Welcome to the Octopus Pharmacist channel. This is a new episode of From A to Z Product. In this series, we take one product and explain everything about it in a clear and detailed way. And first, this is the title of today's episode. If you're looking for a specific title or a specific piece of information, you can go directly to the video section that matches this title. But if you want to know everything about esketamine, stay with me from beginning to end. As usual, let us start with a simple overview and see how much basic information our minds can easily understand. First, let us think together about the steps used to treat depression. We discuss these details in a separate episode, and I will leave the link to that episode in the description below the video. When it comes to diagnosing mental health conditions in general, we do not have a blood test that can directly tell us what the psychiatric condition is. However, the doctor may request some tests to rule out other causes. For example, vitamin D deficiency can sometimes cause symptoms that look similar to depression. If we give vitamin D and the person returns to normal, does that mean the psychological condition has been confirmed? No. The vitamin D test is used to help exclude other possible causes that may confuse us with psychiatric symptoms. The second point is that in depression and many other mental health conditions, diagnosis is often based on a questionnaire. This is a set of questions that the doctor asks the patient, or sometimes the patient's family. And in the end, the doctor gives a score or grade, then starts making the diagnosis. There are many types of these questionnaires, some well validated, and some used to describe psychiatric symptoms in more detail. We talked about this point before in detail. The next point is that we have a scale the doctor can use to determine the severity of depression, not the diagnosis itself. So the doctor can know whether depression is mild, moderate, or severe. This scale is called the Hamilton Depression Rating Scale. The next point is, how do the steps of depression treatment work? The first group of medicines we usually use is the SSRI group, or selective serotonin reuptake inhibitors, such as sertraline, fluoxetine, and escitalopram. The doctor starts treatment and tells the patient to continue it for 6 weeks, then come back. After 6 weeks, there may not be a 100% improvement. Keep in mind that antidepressant medicines are not fast-acting medicines. The body needs time before it starts to respond. In a few minutes, we will understand the reason behind this. Suppose the patient and the doctor see an acceptable response. The doctor may then tell the patient to continue the same treatment for 3 months and then return again. After 3 months, we may see about a 50% reduction in symptoms. If we reach this stage, what does the doctor do? He tells the patient to continue the same treatment for 1 year. After 1 year, the doctor begins to stop the treatment gradually. The second step in depression treatment is when the treatment does not work well enough. What does the doctor do then? He changes the treatment to another medicine from the same group, also from the SSRI group. In the third step, if the second type still does not work, the doctor may switch to a medicine from another group, usually an SNRI. These are serotonin norepinephrine reuptake inhibitors, such as duloxetine, venlafaxine, and others. The doctor then follows the same treatment plan used with the SSRI group. If the third step does not work, the doctor may switch again, often to another medicine from the same SNRI group. With these treatment steps, many patients improve, and many people respond well to these medicines. But we must always remember that no antidepressant should be stopped suddenly by the patient on their own. It must be reduced gradually. Why? Because if a person stops a medicine suddenly, depression symptoms may return strongly. The next point, which we mentioned a moment ago, is that antidepressants usually need about 4 to 6 weeks, and sometimes up to 8 weeks, before they start showing clear results. This is because these medicines help the brain adapt and may increase factors such as BDNF, which supports nerve function and recovery. Brain-derived neurotrophic factor is important for brain cells and nerve pathways. For these changes to happen properly, the brain needs time, often around 6 to 8 weeks. So when we use these medicines, we must make it clear that the patient will not simply take one pill, sleep, and wake up fully well the next day. No, treatment for depression takes time before results appear. The next point is very important. Sometimes a doctor finds a medicine is helping, but the result is not complete. In that case, he may add another medicine, or sometimes a supplement such as vitamins or minerals to help support the treatment. For example, the doctor may recommend psychotherapy sessions, which we call CBT or cognitive behavioral therapy. The doctor may also add vitamin D if there's a deficiency, or sometimes even continue it in a usual daily dose if needed. He may add a very small dose of levothyroxine in selected cases, or add omega-3, fish oil, folic acid, vitamin B complex, including B1, B6, and B12, or S-adenosylmethionine. All of these may help support treatment in some patients, and may also help the brain's recovery processes. The next point is, suppose the doctor has done all of this, but the results are still weak, or he already knows from the beginning that this is treatment-resistant depression. This type of depression does not respond well enough to standard treatment. Then what does the doctor do? He adds another medicine, not supplements such as herbs and similar products. Here, we call this combination therapy. The doctor chooses the best medicine from the SSRI or SNRI groups, gets the best possible response, and then adds something like bupropion, aripiprazole, quetiapine, or lithium. Or the doctor may add TMS sessions, which means transcranial magnetic stimulation. Or he may add ECT, which means electroconvulsive therapy. And more recently, the doctor may add Esketamine or Spravato to a depression medicine that already gave a reasonable response. The second topic today is this. After we understand the basic steps the doctor uses to treat depression, and after we introduce Esketamine, let us see how it works in the brain. What is its mechanism of action? Keep in mind that this medicine acts mainly on an important receptor called the NMDA receptor, which responds to glutamate. This receptor is found in the brain, and it has many important functions. Its main role is to support learning, memory, and normal brain communication. But when its activity becomes too high, problems can appear. Too much NMDA activity may contribute to nerve stress and damage, increased seizure risk, more pain sensitivity, hallucinations, and, in some brain diseases, gradual nerve loss, as seen in conditions such as Alzheimer's disease. Excessive activity in this pathway has also been linked with anxiety and depression. That is why a medicine that reduces NMDA receptor activity may help improve depressive symptoms. The main effect of esketamine is to reduce this activity, and as a result, it may help ease depression more quickly in some patients. Over time, this can support brain adaptation, help restore normal signaling, and lead to a clear improvement in depressive symptoms. The third topic we have today, and this is a very important topic, is what is esketamine? Be careful. This medicine is not taken at home. It is given only in a specialized clinic or a hospital under medical supervision. And do not forget, this medicine is not used alone to treat depression. It must be used as an add-on together with a depression medicine such as an SSRI or an SNRI. In the first month of treatment, the doctor usually gives a small dose, 28 milligrams, twice a week. In the second month, the dose is usually 56 milligrams, twice a week. At the beginning of the third month, the doctor starts to evaluate the patient's condition and decides whether to continue with the same dose. It may remain 56 milligrams, or it may be increased to 84 milligrams, still twice a week, depending on the patient's response and overall condition. The first and second months are usually fixed with no change in the schedule. But at the beginning of the third month, The decision depends on the patient's condition. The main advantage of Spravato is that when it is used with a depression medicine, it may improve symptoms more quickly, especially in the early weeks of treatment, and it may also help reduce suicidal thoughts in some patients. The fourth topic we have today, and this is a very important topic, especially for the doctors who will use this medicine, is what are the most important instructions written in the prescription when we use Spravato? The first point, for the kidney patient, there's usually no problem and no specific dose change is needed because of the kidneys. The second point, for the liver patient, liver function tests should be checked every 3 to 6 months to see whether liver enzymes have increased or not. In general, a temporary rise in liver enzymes up to about 3 to 5 times the baseline may be tolerated, but if the increase is greater than that, treatment should be stopped and the patient should be reassessed. The third, and very important, point is blood pressure monitoring. That is one of the main reasons this treatment must be given in a clinic or hospital. This medicine can raise blood pressure, which is well known with ketamine and esketamine. After the dose is given, the patient should stay under observation for about 40 minutes. If blood pressure does not rise, the patient can go home. If blood pressure rises, we continue to monitor it until it returns to normal. In some patients, observation may continue for up to 2 hours. If blood pressure is still high after that, the doctor must take the necessary steps to lower it safely. The next point, the patient should not eat or drink for at least 2 hours before treatment. Why? Because food and fluids can increase the risk of nausea and vomiting after the medicine is given. The next point, the patient should not use any other nasal medicine, such as a nasal decongestant, and should avoid other medicines that may affect the nose or sedation unless the doctor approves them. Also, it is better not to use a nasal medicine shortly before taking esketamine, and usually it should be separated by at least 1 hour, or longer the doctor advises. The next point, after using esketamine for about 1 to 2 hours, the patient may feel nausea, mild sleepiness, poor balance, dizziness, or a temporary slowing of breathing. These effects can happen, and that is why the patient stays under medical observation for a while after treatment. The next point, this medicine is not approved for children or adolescents under 18 years of age. In younger patients, the safety and benefit are not established in the same way as in adults. But in adults, especially those with treatment-resistant depression, this medicine can help reduce depressive symptoms, and in some cases may help reduce suicidal thoughts when used with proper medical care. The last point, and a very important one, this medicine has a risk of misuse and dependence. For that reason, it should not be used in people with a current or past history of substance misuse unless the doctor carefully decides the benefit is greater than the risk. Because of this risk, the medicine is used under a special safety program with strict medical supervision. The fifth and penultimate topic today is, what are the side effects of this medicine? What are the interactions with other drugs? What are the contraindications? In other words, is esketamine ever completely forbidden? The first point about side effects is that some of them are expected, and they do not usually require stopping treatment or reducing the dose. The most common side effects include nausea, sleepiness, and sometimes unusual eye movements. Some patients may also feel dizzy, disconnected, or temporarily unsteady. These effects are usually short-lived, appear soon after the medicine is used, and then disappear. The main contraindications are related to 2 important situations. First, people with a history of serious problems caused by this medicine, such as severe sedation or abnormal reactions, should be assessed very carefully before use. Second, people with intracranial bleeding or increased risk of bleeding in the brain should not use it, because the medicine may increase blood pressure and worsen the situation. As for drug interactions, esketamine has several important ones. The first is that it should not be used with opioids, alcohol, or other substances that depress the central nervous system, because this combination can increase drowsiness, slow reaction time, and cause a strong loss of balance or deeper sedation. The second interaction is with antidepressants. You may wonder, how can that be if esketamine is used with antidepressants? The answer is that it is usually used together with an antidepressant, but the doctor must be careful with the dose and the overall treatment plan. In practice, the antidepressant is not usually started at a very high dose at the same time. The doctor may begin with a low dose, then increase it gradually while monitoring the patient. Why? Because combining esketamine with SSRIs or SNRIs may increase the risk of serotonin syndrome, which is rare but serious and potentially dangerous. The third interaction is with medicines that change the activity of liver enzymes, especially CYP3A4. Drugs such as rifampin, carbamazepine, ketoconazole, and erythromycin may affect how esketamine is broken down in the body, so the effect may become weaker or stronger. The fourth interaction is very important, and it can be dangerous. Esketamine should not be combined with MAO inhibitors. MAO inhibitors are an important group of antidepressants, but when used together with esketamine, they may raise blood pressure sharply and increase the risk of a hypertensive crisis. The sixth and last topic today is, should we use esketamine during pregnancy, breastfeeding, or in older adults or not? The first point is pregnancy. In general, this medicine is not recommended during pregnancy because there is still not enough strong safety data in pregnant women. Also, the medicine may pose a risk to the mother and, potentially, to the developing fetus. For depression during pregnancy, doctors usually prefer treatments with better established safety data, such as certain SSRIs, chosen carefully based on the patient's condition. As for breastfeeding, it is also usually not recommended because the medicine may pass into breast milk and reach the nursing infant, which could cause unwanted effects. As for use in elderly, there is usually no specific dose change needed just because of age, but the doctor must still follow the same safety precautions we discussed earlier for Spravato or esketamine. So, our discussion today about Spravato or esketamine ends here. I hope I have given you useful and clear information. At the end, if you like the video content in the channel, please subscribe, and share. And do not forget to support the channel on Patreon, PayPal, and YouTube. Have a nice day.